Surgical care is generally very safe. Only about 0.5% of patients die after surgical care in developed countries. This paper is about those few patients who did die after surgery. We assume that increased age signifies the need for increased surgical care. In our paper, we examined the relationships between increasing age and markers of post-operative care in adults who died in hospital after surgery in Australia. Today we will discuss further the post-operative findings in this study. It is a cross-sectional study, extracted data from a national surgical audit. This is a mortality audit using an independent peer-reviewed process. This is a unique surgeon-driven quality assurance activity approved by the Commonwealth of Australia. From January 2009 to December 2012, 111 public hospitals and 61 private hospitals in Australia notified the audit. The deaths were in-hospital deaths, involved surgery requiring general anaesthesia, and included patients who were admitted under a surgeon. Notified deaths totalled over 19,000. We excluded deaths if patients were brain dead, younger than 17 years, or did not have an operation during that admission. 11,201 were divided into three age groups: youngest, medium and oldest. The oldest group numbered almost 5,000, and we were able to demonstrate relationships between increasing age and markers of post-operative care. Six of 8 post-operative measures demonstrate strong, significant relationship with increasing age. You'll see from the graph that the top line represents treated in ICU. You will see with increasing age there is a drop from the mid-80s down to 60% in the oldest age group. We calculated odds ratios for each variable, comparing by age group. We adjusted for ASA class, type of admission, presence of comorbidities, and whether the patient was transferred, whether the diagnosis was delayed, or whether malignancy was present. Levels of care than the medium and youngest age groups, and decreased resource use. Care in the oldest age groups compared with the median was less aggressive or appropriately scaled down. Decreased unplanned return to theatre in particular, decreased unplanned intensive care admission, and decreased treatment in intensive care. The detection of post-operative complications was lowest in the oldest age group, even with virtually all having multiple comorbidities, suggesting a culture of less intensive investigation, monitoring, and possible failure to intervene in the elderly. In most cases, it may be appropriate not to pursue further measures in futile situations, but only after serious consideration by all parties involved. The management decision with these oldest patients therefore must be influenced by the patient's functional, physiological, psychological and social condition. We could not determine from our data why the oldest group had care scaled back after surgery, but we believe that careful assessment at all ages is critical. We believe that there are important implications from these results. Findings indicate a willingness to offer an operation at presentation, but early withdrawal of treatment if complications occur, rather than instigation of a palliative care initially. Scoring systems need to be used on an everyday basis in the most elderly surgical population. Surgical costs may increase at a lower rate than expected if older patients continue to have fewer complex post-operative interventions. With the increasing pool of older people, it is likely that these Australian results would be generalisable for all surgical populations. We need to use this information to improve on that already very low rate of surgical patients who die. More work needs to be done on those patients who did not die after surgery, particularly the elderly.